Welcome everyone to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for October 10th, 2024. This conference is being recorded. We have a number of fellow applicants today. We welcome them all. Hope they enjoy the conference. I promise you're not on the wheel. If you don't know what the wheel is, we'll show you. You won't get picked to discuss for the wheel. We're not gonna test you that way. We've got a great case today, some really fun twists and turns. I think it'll be a fun discussion. As usual, we have got nothing to disclose, and the patient's identity has been disguised to protect confidentiality. This is Dr. Baxey's case. I believe he's going to walk us through the history. Praveer?
Yep. So it's good to be back. It's been a while, but I think we have a good case today. So this is a patient that is a 40-year-old Hispanic man who was referred to us for proteinuria. His history was significant for a thoracic aortic aneurysm. He had type B resection. He had an aortic arch repair about 3 years ago. His history is also important for, or I should say very significant for testicular cancer. He had a surgery and lymph node radiation 2 years ago, and he's had some resultant lymphedema as a result of that, but that is thought to be in remission per his oncology team. Hypertension, hyperlipidemia, and also, and the reason he came to the hospital was because of a worsening bilateral lower extremity edema on top of his, lymphedema at baseline and also scrotal edema. Now, he said that he noticed over the past 3 months about an estimated weight gain of actually closer to 75 pounds in the 3 months preceding his admission, with swelling primarily on his legs, thighs, and scrotum. He was admitted twice for this over the course of the last 3 months. He's had Dopplers that have not shown any deep vein thrombosis, and he was giving compression stocks with some improvement, but never back to his usual. His serum albumin was less than 2 when we reviewed these labs and prior admissions. A urinalysis was obtained at his most recent admission, and he had noted proteinuria, which prompted our involvement in the case. We've kind of gone over his medical history. It is important to know that he did have chemotherapy before. He had bleomycin, and he had altered mental status as a result of that, but he has had no other type of chemotherapies since he was diagnosed and has been in remission. He's found to have mildly elevated LFTs in the past as well, and hyperammonemia. He was seen by hepatology, and a liver biopsy was done that showed maybe mild centrilobal sinusoidal fibrosis, and they were concerned that this was more overall from Lipitor or Diovan. And there was not much follow-up after that. He was pretty stable in terms of his LFTs, and he was following hepatology every so often. When you see him in terms of exam, which we'll go in more detail, he did have kind of acromegaly-like features of his head, and this had been worked up in the past. He did not appear marfanoid, and there was no definitive diagnosis for that. He was not thought to have Marfan's. He's had a little bit of a mild thrombocytopenia for the past year, and he's been seen by the hematologist, and this was thought to be likely from radiation. And there's never been a specific diagnosis for his monocytosis or eosinophilia, but it was not new. So when he saw us, he was anasarcic on exam. His albumin was now down to 1 from his usual above around 2 baseline, and his creatinine was 0.9, which is consistent with his prior labs. The urinalysis showed 4+ protein, 2+ blood, 11 RBCs on high power field, and 4 WBCs. We started a serological workup given his presentation and this urinalysis, and a renal biopsy was arranged. I've gone over all these things. No family history of kidney disease. In terms of other symptoms, he never had a rash or gross hematuria. His main issues were edema and weight gain. Some more, this is kind of this is duplicate information. So if you go down here, his blood pressure was 126/80, heart rate was 75. His weight was now 351. Again, that's about a 75-pound increase from what it was 3 months ago. And he, as I mentioned on exam, besides the anasarca, he had these acromegalic features and some facial swelling, which again is not new and has been worked up in the past without a clear etiology. He had a systolic murmur, 2 out of 6, and I said he was anasarcic and it was pitting, 3+ pitting edema, There was no rash. His other laboratory findings at the time of eval, his bicarb was 21, B111, creatinine 0.92. His albumin was 1 with a total protein of 3.1. His AST, LTs at this time were normal. Alk phos was just mildly above the normal range, if not just within the normal. Bilirubin 0.6, cholesterol 183. His hemoglobin was 12.2. He had a 21% eosinophil count, eosinophil percentage. Monocytes were 12.3, also high. His neutrophils on the lower side. His platelets were mildly low again, which is not new, at 109K. His UA, which I mentioned, his UPC ratio was 3.5 with the corresponding UAC ratio of 2.1 grams per gram. Serological workup, as noted here, not remarkable. Everything was negative or normal. His kappa lambda free light chain ratio was 1.36, and his microbiology workup was also negative. As part of this hyperammonemia, he had serum amino acids measured as well. 10 were abnormally high, but 3 abnormally low. This was thought to be more from a urea cycle defect from hepatology's assessment and not due to his very mild fibrosis or mild liver disease that they had seen on the liver biopsy. Kidney ultrasound showed normal sized kidneys without hydronephrosis, and a kidney biopsy was performed.
So any questions?
Was this testicular cancer deemed to be in complete remission?
He had seen oncology right before admission, and he had CAT scan, and that was thought to be in remission.
Did he have undescended testes from birth?
Did he say, I'm sorry, can you say that again?
Did he have undescended testes from birth?
Not that I know of. No, not that I know of, not that he could remember.
Did he ever have any genetic studies done?
No, not on file.
Endocrine had seen him and worked him up for this, what, really looked like acromegaly, but they determined that he doesn't have that. And it was also interesting that he had this dissection at a relatively young age, but he did not look marfanoid the slightest bit. Not that completely rules it out, but no, he's not had any complete workup for either of these, kind of odd phenotypes. And whether it's related to this or not, I don't know, but it's just kind of interesting that someone this young would have all this stuff going on. It's kind of incredible, really.
What about an
One more
RPR?
question, Roger. Is the neutropenia and the eosinophilia new, or has that been a part of his syndrome prior to the onset of nephrotic syndrome?
This has been part of it, and he was evaluated by hematology, and really no specific diagnosis was made. And
Okay.
In their notes, I only found one note, but in their notes, they thought that thrombocytopenia was related to his radiation therapy, but I never saw a comment on the other cell types. But I think they were all after his cancer diagnosis, maybe somehow related to chemotherapy or radiation or both. Dr. Rubin, you had a question?
Yeah, I was wondering if he was tested for syphilis.
a great question. I can find out. I don't remember, but I can check.
Thank you.
And then was his renal biopsy complicated or uncomplicated?
Uncomplicated.
What was his BMI, Dr. Pepsi?
His BMI was
45, maybe.
yeah, I can calculate it out. I actually didn't. I will put that in the chat, but I mean, it was like I think it was like in the mid-40s, if I remember correctly.
Yeah, that's
Okay.
my bad. I was helping with the protocol, and I had every intention of putting it in, and I overlooked it. It's right in his charts.
It's in the I would say about 45. It was CT guided. Yeah, about 40, 45.
Did the hematology didn't think it was a myelofibrosis type of picture with so high monocytes and slightly low platelets and slightly low white cells?
No, I mean they didn't comment on it. This was all they were focused on the thrombocytopenia, and the eosinophilia was not new, and like as Roger said, it was never mentioned. His syphilis was negative, and that was checked on admission.
It's a good question. I like it. All right, I'm going to hand it over to Dr. Gashti to give us a differential diagnosis here. I'm expecting some crazy syndrome that includes phenotypic features and bone marrow features and urea features and proteinuria.
I will get right on that. I'll come up with the Gashty syndrome. No, I mean, this gentleman has a lot of findings that don't necessarily all, at least I can't put them all together in one diagnosis. So he may have multiple things going on. I mean, a 40-year-old who has already had major vascular procedure with aortic arch repair and aneurysms, with marfanoid features or acromegalic features. I think Dr. Rubin, I think, brought up the idea of genetic testing. I think that's an excellent idea. And usually when I think of renal disease associated with some of these genetic diseases, it ends up usually being some kind of an FSGS. So that's one of the things that I would, present with, nephrotic syndrome, some hematuria, really low serum albumin of 1. Although, the BMI makes you think maybe is there a secondary FSGS, but the low albumin doesn't really fit that. Usually secondary FSGS doesn't present with this degree of nephrotic syndrome. So FSGS is on the differential as far as, what kind. The albumin being so low, it could be, it could have a tip lesion, it could have like a variety of different histologic manifestations, but at least spectrum of disease. Membranous is on the differential. I know PLA2R is negative. The guy has had malignancies, so whether he has a PLA2R negative primary membranous or a secondary membranous from malignancy, and I guess syphilis was ruled out, that's on the differential. So membranous, focal sclerosis, pattern of injury. Minimal change disease, again, this looks like relatively sudden onset, 50 pounds in a short period of time would fit that. The serum albumin of 1 will fit that. The cholesterol not being very high, although the patient is on a statin, doesn't necessarily fit that. The degree of albumin and total protein in the urine, it's a 2 grams of albuminuria and 3 grams of proteinuria, am I right? So that's about definitely less than 90% for sure. So it's not necessarily selective albuminuria. So that also maybe moves the needle a little bit away from minimal change disease, but that's also there. We seem like we have ruled out, at least based on serologies, things like lupus. IgA nephropathy is on the differential still. Hematuria, proteinuria, I would say, I feel like that's, I don't think I've seen a serum albumin of 1 with IgA, unless the patient is actually really sick. It just seems like 3 grams shouldn't have an albumin of 1. Paraprotein-related diseases have been ruled out. It seems like SPEP, UPEP, and immunofixation, negative, kappa-lambda ratio are normal. Amyloid is a possibility with a normal serum creatinine. The patient does not necessarily have, well, the blood pressure is good, but the patient is on antihypertensive. So that's kind of my differential is membranous, focal sclerosis, pattern of injury, IgA nephropathy, less likely to have minimal change, although the history actually does fit that. So that's also on the differential. Amyloid could be a possibility. I'm thinking FSGS just based on all these odd things that we don't know what they're about. I mean, this patient has these hematological malignancies we really have no answer for. 20% peripheral eosinophilia, and even on a chronic basis, should at least have a diagnosis. And I don't think that's ever chemo related. So I don't know if there's an undiagnosed hematological problem that ties into this. I don't have much else to add, but that's kind of my limited differential.
Does the hematuria sway you one way or the other?
The hematuria, I mean, the IgA, the membranous, and the focal sclerosis, they can all have hematuria. Minimal change would technically not have as much hematuria, so that would be something that would make me think less minimal change. But I mean, the original description of focal sclerosis was hematuria along with proteinuria, so that does not necessarily differentiate any of those 3 for me.
Anybody out there have any strong feelings about anything else? In the chat was brought ALEC2. Of course, that his demographic kind of fits that, but this is way too much proteinuria for that, or at least too much nephrotic syndrome for that. I mean, it tends to be interstitial.
Yeah.
Plus, you'd expect the creatinine to be higher, wouldn't you? I mean, it's usually they present with some chronic kidney disease. The other issue that Casey brought up with the amyloid, I mean, the patient had a liver biopsy, right?
Yes.
A ways
So I
back.
assume they checked the liver biopsy for amyloid.
The liver biopsy was a ways back, though.
The serum albumin of 1 and a cholesterol which is close to normal would strongly vote against minimal change disease or FSGS. Although the patient does have liver disease, which I think is the confounding issue here, is his hypoalbuminemia, a combination of nephrotic syndrome and liver disease. That certainly would be implied with a urinary protein to creatinine ratio of 3.5 that this is not a simple nephrotic syndrome. This is a nephrotic state in a patient with liver disease.
The thing is, when they
I would frankly focus on the hypereosinophilia, which is very intriguing. There's very few diseases that cause both kidney disease and hypereosinophilia, even though it was chronic and did precede the development of the kidney disease. I suppose you would probably have to include IgG4 related disease because of the hypereosinophilia, which would link to membranous nephropathy, because that's one of the lesions that you see in the kidney in patients with nephrotic syndrome and IgG4 disease. So I would be interesting to do an IgG4 level. Aortic aneurysms are increased in patients with IgG4 related disease because of the aortitis that is commonly seen in that disease, but I'm not aware of testicular cancer or any of the other manifestations, the acromegalic features. That doesn't suggest to me anything.
his his pro time was normal, and the liver biopsy just showed minimal fibrosis. The hepatology really thought this was very minimal liver disease, at least from the standpoint of albumin production. I think that we still had the same problem, or Prevere is his case, of course, had the same kind of issue, that his hypoalbuminemia seemed awfully out of proportion to his proteinuria.
Yeah, and in fact, I think we were consulted after hepatology had seen him and GI, and they said we're not doing a scope. They were worried about protein, enteric loss of protein, and then someone checked a UAC, UPC, and then they called us. Liver, hepatology, and GI had already seen them.
Yeah, it's kind of funny. This guy's gained 75 pounds, and they're looking for, intestinal clotting disease, intestinal disease, and they're not even have any focus on the kidney as the cause of his hypoalbuminemia. In fact, I'm not even sure they put it all together, the edema, because they were looking for DVT initially. Is that correct, Prevere?
Yeah, they weren't even thinking kidney. He'd been there, and then finally, out of options, and they called us. I think they were thinking that this is, just hypoalbumemic state, and no one was really thinking kidney because his kidney function was normal.
And it may go against minimal change a little bit because of the chronicity. I mean, you said you went back and you saw some low albumins already from before, and that's such a trigger for us to then check your analysis. But it's amazing that it's not a trigger for every provider. And I like trying to link this eosinophilia too. It's funny, most of our eosinophilic renal conditions are not nephrotic syndrome. So I'm glad Dr. Glassick was able to bring in a unique one that, with the membranous and the IgG4, because we're typically thinking, could it be something like Trigg-Strauss, which would be more renal failure, or even interstitial nephritis, which would be more renal failure. And that would be renal failure out of proportion to nephrotic syndrome. And here we have the striking opposite of that, which is, a lot of proteinuria, or enough proteinuria to really be nephrotic syndrome, but still a relatively, or normal serum creatinine.
Sarcoid can also be associated with the membranous, but I mean, again, I assume the liver biopsy would have been one way to help make that diagnosis too. The other thing is, and Dr. Glassy can address this as well, but I mean, we've seen patients in the past who have such severe hypoalbuminemia that their urine proteins are quite low. And the next thing you know, you start giving them albumin infusions and the protein levels in the urine start to skyrocket. And so I just wonder to some degree if what we're seeing here in the urine protein and albumin creatinine ratio is a function of this guy's severely low serum albumin.
You just illustrated the concept of filter load. I love it.
Yeah, I don't love it.
Well, I don't care if you love it or not. I just think it's
Yeah.
just something that has to be considered.
No, I think it's a good. I think it's worth asking about because we see patients that have albumins of 1 and their proteinuria isn't up there, and we think, well, that is a filtered load. I mean, it's obviously a very important physiologic concept. The thing is, you see plenty of people with albumins of 1, and they still have 20 and 30 grams of protein. So I don't know. I don't know that it's that simple. I'd love it. I'd love that to be the case. It's just not. You'd think if that were the case, that would be a little more universal. I don't know.
Well, there's a spectrum.
Yeah.
Spectrum. Everything's a
When
spectrum.
when an albumin of 1 is attributed entirely to increased filtration of albumin and excretion of albumin, to have a cholesterol of this value would be, I mean, magnificently exceptional.
But Dick, it was pointed out.
Combination of a low cholesterol.
But we see
normal
that in focal
cholesterol.
sclerosis. They don't always have hypercholesterolemia. And, you think that the increased production of albumin by the liver and HMG-CoA being upregulated would increase the cholesterol, but we don't always see that. And we've talked about that before in this conference.
But Dr. Gashti already pointed out the gentleman was taking a statin. So let's keep that in mind. The other differential in a Hispanic with eosinophilia is a parasite that may also be associated with membranous.
No travel or anything, Pravir?
No, no travel, no other really nothing.
Okay. I mean, as long as we're covering the eosinophilia, I think it's also, this is irrelevant, but atherosclerotic disease is another, but that doesn't fit anything here, so we'll just kind of move on. Should we take a look at the pathology?
Yeah.
Updated wheel here.
That's the video. That's not the real
That's the
wheel.
video. Yep, we're not gonna. Let's see who it lands on. Actually, who does that land on? Oh my God, still Bobna.
All right, put up the wheel.
This is not a video. Yeah.
It is Bob after all. How funny.
Sorry, Bobna.
Bob is one of our super second year fellows who can handle this. I'm quite confident.
Make co-host. Hold on. Give you control here.
Gashti Bobna disease.
Can you hear me?
Yes. Not again. That's just rubbing it in. That's just rubbing it in now. Go ahead, click. Go ahead, click.
Okay.
That's you.
Okay. So we have one core here. You can see a couple gloms here. Tubules look pretty close back to back. Not much. This looks to be like medulla. Maybe like 15 to 20% fibrosis.
Yeah, it's kind of focal. Actually, that area in the bottom right, I think, is the capsule and the connective
this?
tissue.
Oh,
Yeah,
okay.
there's a little subcapsular fibrosis, but yeah, overall, it was just focal.
Okay.
Yep.
Okay, we have H&E, one glom in the middle here. Looks fairly good. I see some mesangial expansion, hypercellularity here.
Yeah, so you're at the
That's the
you're at
hilum.
the
Okay.
hilum. Yeah, so you
Okay.
want to look at the periphery.
Perfect. Okay, yeah, I was gonna say that kind of look like hilum. Right here, maybe some hypercellularity. This kind of
Overall,
looks a little
overall
thickened.
doesn't look too bad.
Yeah.
Huh?
Yeah, no like
Yeah.
segmental scars. This looked a little thick to me.
Okay.
Okay.
Yeah, it's subtle, but the capillary walls do look a little thickened to me, especially like at 12 and 11 o'clock.
Like here.
Not that this was really part of the
right there.
differential,
Yeah.
but it doesn't look like there's glomerulomegaly either.
Right.
Yep, no glomerulomegaly, Dr. Bill.
Okay. And then the tubules around look pretty back to back. I don't see any like debris inside the tubules to suggest ATN.
Okay.
Okay. And then we have a PAS stain. Again, this is probably the hilum, but otherwise, I don't see much super hypercellularity or expansion.
Yeah.
Yeah, I don't see
Yeah, so
anything
far,
there.
yeah. Looks like a pretty normal glomerulus.
Okay, and then PAS stain again. This kind of looks a little shriveled here. I mean, I can't really make out the entire
Yeah, so there's a segmental
segmental
scar right
scar.
there, that
Okay.
area of consolidation.
Okay.
Yeah. So one had a segmental scar.
Okay.
And the interstitium looks fine, no IgG4 disease. That was thrown out there in the differential, no interstitial infiltrates.
Yeah, otherwise I mean, just this scar here.
Yep.
And then we have Jones or Silverstein. These
David,
little
this
spikes
looks a
here.
little, I'm sorry, David,
Yeah.
this looks a little dark. Is it,
It's a thick, yeah, it's a little thick overstained section.
okay.
But yeah, look at 11 o'clock, 10 o'clock.
Here.
Those
look like spikes to me.
yeah.
Maybe a little over here too. And maybe here. But I don't
Yes.
see them anywhere else really. I think more so over here. And then no holes. I mean, this area kind of looks like a moth-eaten appearance with holes, but I mean, I don't see it anywhere else.
Yeah, that's the mesangial area. So when we want to evaluate the GBM on the silver stain, but yeah, kind of that segmental spikes up there in the periphery.
Okay. So immunofluorescence showed 2+ mesangial and glomerular capillary wall positivity for IgM with trace IgA, negative IgG, trace C1q, trace 1+ kappa, 1 to 2+ lambda, negative IgG1, negative IgG2, negative IgG3, and negative IgG4. And the Congo red was negative.
David, your general impression, this was pretty much, it was negative IF?
Yeah, it wasn't very impressive.
Where's the?
So we'll have more, but we're gonna do this sequentially here. So, what's your histopathologic description, Bhavna?
I mean, for the most part, most of the glomeruli look good with no like lesions except for that one segmental lesion. There was the Jones stain with, that focal area of spikes, could be epithelial deposits. I mean, we don't know, but it could possibly be. But otherwise, there was just one segmental scar.
And I mean the problem there is that the IgG was was really negative.
Are you
Look,
hiding?
I mean there's this
the,
disconnect between the disconnect between the silver and the IF. I'm sorry, Dick.
are you hiding the EM from us intentionally?
Well, no, we will show you the EM, but this is how it happens. We get this back, and the EMs are sent away, and it can take over a week. So we're going to present it as we got it.
Yeah, it was actually a Friday when we got these preliminary findings.
So David, was the IgM in the mesangium and in the capillary walls, or was just in the mesangium?
No, it was both, but it was weak and segmental and just not very impressive.
Well, when you see a biopsy that's negative for IgG that shows a suggestion of spikes, on light microscopy, this could be concealed membranous, so you'd immediately want to do a pronase, I think.
And the amyloid would be consideration too, but I know the Congo red is negative because those can be pretty big spikes, segmental as well.
Good point. So, along the lines of the questions, the EMs will take 7 to 10 days. So this is just a very simple poll. Would you start prednisone now? Or would you wait for the EMs before starting anything? This we'll go over maybe the argument for that.
Right now, we're dealing with, we had FSGS with pattern of injury with nephrotic syndrome.
Fairly severe nephrotic syndrome.
I'm not exactly sure why you included prednisone now in this poll, Roger.
You'll find out.
You mean under the assumption that this is primary FSGS?
Under the assumption that this is a podocytopathy, yes. Under the possibility that it's podocytopathy, yes. Is that fair, Pravir?
Yeah, that
spikes?
exactly, because you know, that there was nothing there as this is basically, is this a podocytopathy? That's how he's presenting, weight gain, nephrotic syndrome, without any clear evidence of membranous.
I must say those spikes are pretty hard to ignore.
Well, we can end the poll, and in spite of Dr. Glassick's strong argument that prednisone he would never consider starting prednisone, somehow we talked 47% of people into at least considering it.
Okay.
But your point's well taken. I mean, it's like dueling, dueling findings. You've got a negative IF and you've got an impressive overly exposed silver. So it kind of, pick your poison or pick your diagnosis. So next slide. So Casey, what do you think about what we see so far?
Well, I don't think, I mean, the spikes make me think this is membranous. I mean, yeah, we do see some of those in amyloid, but I mean, we have a Congo red that's negative. So we saw one segmental scar in all of these gloms, and we see pretty impressive spikes. And so why couldn't this just be membranous with some segmental scarring? In which case I wouldn't do steroids. I don't know how long this guy, I mean, he's been nephrotic for a long time. I don't know if I would necessarily pull the trigger on steroids now. I would wait for the EM. That's gonna hopefully shed a lot of lights, right? If you confirm membranous, then we go a different route. It's not steroids. If you see a diffuse podocytopathy, then you can make a case for steroids. So I would hold off on the steroids until I get the EM is what I would do.
Yeah, and he doesn't have renal failure, and it's been going on a couple months, so I'm not sure a couple extra days is going to be a big deal to wait. If there's foot process effacement, membranous can have that too. So you really need to see the if there's deposits on the EM. And kind of maybe hone in on what that was. A segmental membranous is classically described with NEL1, and we know the PLA2R is negative. So that's a consideration also.
Does that thick of a cut on the Jones stain influence, or that kind of a cut, does that influence your IF, David?
Well, so the spikes were only in this one out of several glomeruli. They weren't like widespread. So it's just very focal here.
But the patient is PLA2R negative. So if it's membranous, the top choice is NEL. And NEL is a segmental disease. So in poll number 1, I would have put, just to be an irritant, Roger, I'm getting under your skin a little bit here, but start anticoagulation now.
So
serum albumin of 1, a possible diagnosis of either membranous or minimal change disease or FSGS with 400, body weight. This guy needs anticoagulants, in my opinion, right now.
fair enough, and we'll get to that too. So Dick,
Okay.
you could never get under my skin.
Okay.
So we can tell you what kind of we did. So again, the albumin was 1. Given that initially this was considered a podocytopathy with exactly minimal change or FSGS is what I was thinking initially, primary FSGS. So I did start prednisone because again, the EMs can take about 2 weeks. Sometimes it's taken longer. And after 5 days, we did put him on anticoagulation after the biopsy. So I put him on Eliquis. He was, and then I saw him in clinic. His edema was no better. His creatinine is now 2. And when he came to me, he was short of breath and just not looking right. So what I did is I sent him to the hospital from clinic. And what happened over time is his ammonia levels found to be 189, and slowly he became altered and tunded. and he was not responding to diuretics and required intubation. He became oliguric, and ultimately we had to start CRT for him for both volume overload as well as hyperammonemia. And fortunately, I guess that's kind of where we are. Is that? Let's see.
Did his BUN increase a lot more than his creatinine with the steroids and this urea
No,
cycle
it
defect?
wasn't. It was kind of like it was not disproportionate, and just it was pretty. Both got. BUN actually didn't get that much higher. It was more the creatinine went up.
It was pretty remarkable. He'd already been on steroids, for a little bit, and it was pretty remarkable how awful this guy's mental status. I mean, he just went completely down the tubes. And to be honest, hey, if we didn't have this history of ammonia, not sure it would have been picked up as quickly as it did, but he had this history, so you were able to check ammonia. It's not something people often think of with mental status. It's kind of the last thing you think of, especially when there's no real liver history. I've seen a urea, I don't know that this diagnosis is for sure, a urea cycle defect, but I've only seen it one other time in a patient where it just was very stressed and became obtunded and urea went up. I mean, ammonia went way up and was found to have a urea cycle defect. So it was pretty profound. The guy he completely deteriorated and respiratory failure and we intubated him and then he became oliguric and we had to start dialyzing him. A guy that, ostensibly had, a relatively, treatable or whatever, mild, at least from a renal standpoint, renal disease.
Well,
That's when we first saw him.
isn't steroids an exacerbator of urea cycle defect patients?
So
It seems to be, in this case, probably yes.
I would have thought if it did, it has to do with the fact that you're just more catabolic, and it's like being on a high protein load. The same thing that happened with the other patient I saw. There was a woman that was preeclamptic and was very catabolic. I don't know if steroids have an independent effect on that other than making you catabolic and it's a high protein load. It's a really good question.
I
I was
did
asking about the
I
BUN.
just did a quick AI search on my iPhone. Here's the quote. Corticosteroids can increase the risk of life-threatening hyperammonemia in patients with urea cycle disorders, and they are contraindicated.
Boy,
I'd like to say that I'd like to say that I put that in the chat before checking to AI, and it's my own internal AI. Okay.
You did.
Yeah, but Bill, yours is absolutely artificial. So
That's true.
no, the question is, I mean, it's a really good point, and the question, I mean, how much experience do any of us have with this? It's very, almost none to zero to none. But the question is it something about steroids, or is it just a high protein load? And I don't know if that's known, and I don't know if that's in the article that Dr. Glassick found, who just keeps irritating me with his nagging side comments. So, Kabir, tell us what we did.
So what happened, and clearly that's when, this, again, he had been seen by multiple, GI liver service. And at that point we said, well, there's something going on here. We stopped the steroids. He had already started anticoagulation. I was actually concerned when he initially came in that he had a PE, and that's why I sent him in. They couldn't get a CTPE because his creatinine was up to 2, but he was already on anticoagulation. So they kind of put him on heparin drip temporarily. We gave him lactulose for his hyperammonemia. That got better. And he actually woke up, and we stopped dialysis, and he's still admitted. And now he's out of the ICU. He's awake in times 3 or 4, whatever you want to say. And EM results come back 2 weeks later. So
Before we go there, did you do a D-dimer and Doppler studies of the legs?
The D-dimer was elevated, and that's why we just started. And they did the Dopplers were negative, the D-dimer was elevated, and so the decision was made to just anticoagulate, which we had started Eliquis anyway, but he got started on heparin drip.
Good
Just
move.
out of curiosity, I thought the threshold for ammonia was 250 before you start dialyzing. I realize that it can be anything if you think that that's the cause of his altered mental status, but did he ever get any higher than 180 or?
He did. He got much higher. He was up to like 500 at one point.
But I think, Steve, that threshold's in the setting of liver disease and in urea cycle defects, especially in pediatric. If there's a known urea cycle defect, if the ammonia is high with mental status changes, you start CRT much earlier.
Okay. Well, I assumed we were attributing this initially to liver disease. No?
I think he had a known urea cycle defect.
No, he did not have a known one. They had never diagnosed him. This was all actually what happened out of this is that we were able to convince liver that there's something more going, a hepatology liver, hepatology, and then they had genetics consultation to work up because it was thought that his mild hyperammonemia was just from a little bit of mild liver disease, and this had not been brought up. So he did not have known urea defect cycle prior to the steroids.
This is a
Pra-
clinical,
Pravir,
clinical diagnosis we were trying to make.
What?
Pravir, I have a question. The only liver issue he had was an ischemic hepatopathy due to hypotension at the time of the aortic surgery, correct?
Yes.
Yes,
Okay.
Yeah.
you're
That's-
absolutely right. And a liver biopsy was minimally abnormal.
Yeah, okay. Just clarifying.
So the
Yeah,
elevated
that's
alk
right.
phos was just basically due to his hepatopathy?
Yep. And his ammonia level had been mildly elevated at times for the last year and a half at least.
Because his ALT was completely normal. I mean,
Yes, yes. And that's why hepatology kept on signing off. No further workup was done until he comes in now with this thing after the steroids. And so this is kind of where the EM results come back, which I can just review or how do you want to do it?
You can review it and speed it up. Yeah, I think it's a good idea, Pravir.
So here they come. We send them EM. This is about 2 weeks later. And what you're seeing here, of course, is blood space, urinary space, and you're seeing these clear deposits, which are primarily, David, intramembranous in kind of.
Well, yeah. So an intramembranous deposit down at 5 o'clock. Go down to 5
Oh,
o'clock.
right here. I'm sorry,
Yeah,
I'm sorry,
right
right here.
there. And then over there, that's mesangial interpositioning.
Okay.
Yeah,
chronic
and then on top of that, at 9 o'clock, you have a subepithelial deposit there. Yeah, over there.
On there.
That's being a little partially reabsorbed. Yeah, you got a
And,
mesangial area on the far right. Yeah.
and the podocytes seem pretty effaced here.
Yeah.
So this one view. So
Yeah.
you have a subepithelial deposit, an intramembranous deposit, some mesangial interdisposition, and also on this at least this short review, podocytopathy diffuse. I guess looking at me, this is pretty diffuse. I mean, we have enough here. Diffuse podocytopathy, kind of the same thing. So more intramembranous deposits here again, David.
Yeah, and again,
Not many
those are
stomach-
granular, non-organized.
Yeah.
I mean, this has been
yeah.
going on for a while. This doesn't look like it's any kind of an acute process.
Yeah, you got mark thickening there, and then thinning in other areas. Yeah.
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 Same here. It's more of the same. And these podocytes are completely effaced.
Yeah.
Blood space, urinary space, and then I mean,
And then right there at 5 o'clock, Pravir, from 5 all the way up to 2, those are all being reabsorbed subepithelial and intramembranous deposits. Those clear areas.
oh, right here.
No, good move to the right.
Oh,
a
right
little
here. I'm
bit.
sorry.
Yeah.
Yes.
Yeah, those are
This is going along
reabsorbed
with kind of-
deposits.
Yeah, these are resorb, right? These are all
Yeah.
resorb.
Yep.
This is kind of chronic changes to your GBM from
Big time.
yeah.
Did you get
Interesting. I
him?
don't see any spikes, but
Yeah, and so a closer view of some of these deposits showed this kind of appearance.
Yeah.
Yeah,
some of them have fibrillary substructure.
Yeah. Did you get a mass
I
spec?
promise this is all real time, so exactly how it's being presented here. Since it's election season, I can say I approve
some
of
of
this
these
message.
deposits are being reabsorbed, and they have some, they're forming microfibrils and some different organized structures.
No, but those are pretty impressive.
Yeah.
It's not
yeah.
subtle at
Especially-
all.
Yeah,
So-
it's not subtle.
We'll get to Mario's question. He has said if we did mass spec, we'll get to that.
So this is where I am. He's extubated, off steroids, diuresing now, off of he's still on lactulose, and that's kind of been going on. They're doing genetic testing for urea cycle. What do I do now? His albumin is still 1.2, 1.3. He's anticoagulated. Still has edema.
Put up the poll.
I'm glad you didn't put restart steroids.
What about
Fool me one.
not,
What was it? Fool me once, shame on you. Fool me twice, shame on me. Or so what's the saying?
what about number 5? All of the above.
Yeah, you're not. Yeah, that's definitely a probably the best option. But you have to pick one.
Phone a friend.
No, Mario's absolutely right. I mean, you could argue for all these, and I think we'll just Dr. Bexley will discuss that. I'm just curious what people would do if you're allowed one here.
Could you remind me, was a Congo red stain done on the original?
It was negative.
Yeah, it was negative.
So this, okay, thank you.
Did they
So-
measure the size of these microtubules
No, David, did we get a size or no?
or microfibrils, whatever you want to call them?
They did not give us a size.
No, no.
You remember when George Bush
Yeah, screwed it up. That's exactly
got
what
it the
I
wrong way? Everybody has to remember that there before the grace of God go I when you're in front of the whole world and you completely mess up that. I said,
Yeah.
fool me once, shame on me. Fool me twice, shame on. I don't know. Just don't fool me. It's basically
Yeah.
what he said.
We made sure the steroids were stopped. In fact, I mean, it was a short course, so we didn't even have to taper it. It was kind of abrupt stop without any concern for adrenal insufficiency.
Because share the results. It's our highest one is get mass spec, possibly influenced by Dr. Ruben's question, but there's pretty well distinguished upon all four. Pravir, why don't, for the sake of time, why don't you tell us what you think the role of each of these are, and specifically in this case, and then what was done.
I mean, these are all to kind of see what the deposits are kind of made of. Of course, fibrillar GN, I mean, that'd be very useful for DNA JB9 staining to kind of put that into the picture. I mean, mass spec, I'm not sure if we can even do it on these in this type of case, but I think it'd be very helpful.
Let me ask, if I can interrupt, let me ask the audience, is mass spec of deposits only done if they're Congo red positive, or can you do it on any deposit?
Any deposit.
Because they'll tell you the protein substructure, right? What they're made up of, I'm assuming. So
I mean, the tissue was at Mayo, so Dr. Setti could have done his thing, the laser microdissection mass spec.
So number 5 should have been phone Dr. Setti.
yeah. Pronase digestion, of course, to see if there is some underlying for IgG or anything that we're missing, as kind of was mentioned. If there's something that is hidden that would be now would now be present. We do that a lot for our monoclonal gammopathies. Sometimes there's certain solutions, the way it's processed and the substructure of some of these deposits that after pronase digestion allows them to be brought out by the staining. So all these would be helpful. And I think Dr. Glassick mentioned, which I didn't mention, which I didn't know, I should say, is that kind of a membranous that's hidden with all this could be brought out. I did not know that. I had not known that it could be used for that.
Well, I think you could do it. I mean, if you look at it this way, this is kind of an unknown GN. There was a little bit of an MPGN pattern, and certainly this is not a classic PGN MID, but you can have masked deposits. And the fact that the IF was so negative with these deposits, it's possible that something was masked. And certainly in the PGN MIDs, the lack of a circulating paraprotein doesn't really mean anything, and so you kind of have to have an open mind. So I think it's a very reasonable thing to do, to follow up the very unimpressive immunofluorescence with pronase digestion to see if something were to come out.
Yeah, and then finally, this tissue was at Mayo, and phone a friend. Dr. Nasser, of course, is always an option, and it's actually what I did. So, and this is just a reminder that Tigers play today, up 2-1. Don't let the Tigers get hot. So, so what would you do now? And I should say, so going back, I guess, what Dr. Nasser said is that's what I did. He said that there's not enough tissue for staining for DNA JB9. He felt strongly that this was burnt out membranous, and that pronase digestion or mass spec was not useful or indicated in this case. And this was a case of burnout membranous, which would explain his findings that he's seeing on the kidney biopsy.
So how do you explain the organized deposits?
That's part of the he said that was part of the resolution of the deposits, and they can have that.
I don't know that I've ever seen that.
Yeah, that's shocking.
Yeah.
David,
And I've
did-
seen a lot of organized deposits, but I don't know that I've ever seen burnout membranous with organized deposits like that.
David, didn't you say we had a case similar to that once?
Yeah. You know what? I'll send you the email. I'll send you a picture now and see if you could share it. We did have a case where the
Yep.
membranous deposits were resolving into microtubules and microfibrils.
How long ago was that, David?
It's rare. It's rare, but it is documented. And he felt that these were organizing into procollagen. Had the appearance of procollagen. These fibrils.
So those have periodicity, I thought.
Yeah.
It is interesting that they're only in the places of where you would expect deposits to be, as opposed to, you know, typical fibrillary type structures are not always in sort of a.
I mean, those are randomly oriented microfibrils. It looked like, as Dick had said, you know, he was suggesting whether the amyloid had been checked for Congo red. I mean, those things, I mean, it's amazing that they were fairly, I mean, every one you showed us was really nicely organized. It was almost no guesswork.
But see, a lot of them, Steve, were not organized. If you go back a few slides, a lot of them were.
Well, I mean, these
were granular. Yeah, those are, but a lot of them were just granular and not organized.
Well, I mean, here it's all reabsorbed, and here's not that
Yeah,
high
right
a
there.
power,
Yeah.
but I guess you'd have to go higher to see, because the ones you're showing us that are high powered are definitely organized.
Yeah, and I think he went and he said, like David said, that it was only a few of these, but these
Okay,
were. That's what kind of this guy was a lot of back and forth, and he was very helpful, and we were
interesting.
If
a lot of
he's
emails
calling
and
it
a lot of
membranous,
discussions.
Prevere, then did they do NEL1 and did they do exostocin? Because I think Mayo does some of those.
No,
I mean, Dick, how often have you even seen in burnout with these deposits, IgG completely negative?
I have seen that. It's pretty rare that the resolution leaves no trace of IgG on standard IF, but I've had one or two cases of completely negative IF with burned out members in
Yeah,
EM.
I've
I've never seen structural deposits with fibrillary lesions in a resolving late membranous. So this is news to me. I mean,
yeah, me too. And I mean, I get it if it's negative when they're like stage 5, where they're being reabsorbed
Yeah.
completely. But in
Yeah.
the ones that are intramembranous and there's no massive deposits, that's interesting. I mean, and they even did the subtypes, you know, and nothing was positive. I mean,
And,
that's impressive.
I don't, David, and correct me, there was no NEL1 staining. I think he did anti-PLA2R staining. That was negative. There was no other staining.
Now, Prevere, I don't understand
Yeah,
this.
that's correct. And Roger, if I emailed you the photos of a previous case we had that had those organized deposits, if you're able to share those.
Were they negative for IgG?
Let me check.
Go ahead,
So,
Mario.
well, if you send to SETI the paraffin block, he only needs one glom that he does a laser microdissection and he can do a mass spec. So I don't understand Dr. Nasser saying we don't have enough tissue for mass spec. That doesn't make sense to me.
There was no gloms in the paraffin block that was left. It was a small sample.
That's the reason. Okay.
Well, what about,
Thank you.
can't they do it off the Toluidine blue?
Apparently not.
So it gets
once it's put in methacrylate, which is the Toluidine blue, you can't dissect it.
Ah, okay.
So the question now is, what would you? This is kind of where I am, and not enough tissue for the DNA JB9. They can't get any other mass spec. What do you do now? He's still inpatient. This is when I'm seeing him.
How many gloms were on the biopsy, out of curiosity?
I think there was, David, I think
7-2 globally sclerosed.
IF.
Yeah, put number 4 as go to church.
Did I not do the poll? Let's see. Oh, yeah. We can. And again, yeah.
We don't want to be I don't know what the term is, but maybe we should say instead of going to church,
Stop, Roger. Just stop.
Okay. Thanks,
Just
Steve.
stop. I know where
Thank
you're
you.
going.
Thank
Just
you.
stop.
You're right. Thank you.
Yep,
Thank you.
Yep. So here we are. This is
it's a tough day when Dr. Corbett's telling me to be careful.
yeah.
Yeah, I mean, the more you try, the worse it is.
Steve, you're spot on. Thank you.
The majority say 44% rituximab, 19% repeat biopsy again, which is not easy. He does have elevated BMI. Now he's on anticoagulation, which we're not stopping, and watch and wait. So,
what would you do? Well, here's our Dick.
Well,
you never
not
get to see this final
Roger,
picture.
there is not a single electron dense deposit in this biopsy. There is no evidence of active formation of in situ immune complexes. So, and in the absence of a circulating antibody, how can you justify giving an anti-CD20 antibody? I don't understand that. Is this
So
just
basically, you're saying
desperation? I mean, is this?
No. What I mean, these are the
That's
options.
what-
You've stated your point. The options are absolutely not to steroids initially, and absolutely not to rituximab now.
Yeah,
That's fair.
yeah.
Who else? Who else has a strong opinion?
Arjun,
Well,
you're
Dr. Raj
Yeah.
Shakaran. Dr. Raj Shakaran, what would you do?
I have to tell you, like, this is like a zebra case, a unicorn case. I have no idea what's with all these findings. For the longest time, I thought that this may be an atypical IgM nephropathy, but it just and like Dr. Glasak said, there's nothing, no active deposits, there's no immunoglobulin, no IgG. And I was wondering why the IFTA was so low, and you pointed out probably it's a resolving MGN. I, at this point, perhaps would just start off at the CNI to rapidly reduce the proteinuria and get the edema down, and just see how he does. Because I'm not, I don't know honestly what's going on and why he's presenting this way. I would just give a CNI to get the edema down.
Fair enough.
What's his
Or-
what's his creatinine running right now anyway?
back
We'll,
down
we'll-
to
we'll give you the follow-up now.
No,
Yeah,
no, I'm
so-
just wondering, basing on, the issue of whether you start a CNI or anything else, I think the creatinine level at some point might be a factor too.
Yeah, so perfect segue into the next part. So this is, here we go. So you can see here, this is exactly what happened. I do steroids. Now, he comes in very sick. We have to do CRT, comes down, of course, and then he starts having a spontaneous diuresis. Now, we are diuresing him. He's on, he's on Bumex, he's on metolazone, spironolactone, and now his creatinine is right back down to here. So this is at this point, the EMs are coming back. So he's off CRT. His creatinine's back down to the 0.81 region. This is what I did. I left it alone. I stopped steroids. I did not start any other therapy. I actually didn't want to do anything further. I just wanted him to get out of the hospital and figure everything else out. He'd had a pretty prolonged course. And sure enough, as we started checking his protein, as he's there, now he's over at rehab, his proteinuria starts decreasing. And so now his most recent UPC is actually down to less than a gram. His albumin is still 1.5, 1.8, and his creatinine is down to 1. And this is kind of where I am.
So can you, I texted those EMs. Is there a way you could pull that up?
Oh, yeah.
I mean, he had a significant podocytopathy. There's no question about it.
Yep.
He had a significant podocytopathy. He also had acute renal failure because, we gave him plenty of diuretics when he came in, and nothing happened until his GFR improved. It just spontaneously improved as though, I don't know, he had element of AKI from something.
Nephrosarca.
And he massively diuresed. I mean, it was just, and at the same time his creatinine went down. And
it's
everything
interesting
seemed to
that
get
his
better.
proteinuria-
And then lo and behold, we rechecked the proteinuria a couple weeks later and it's going away. So I don't know. I think while he's pulling up this picture, the way I interpret it is that he had membranous glomerulonephritis. I mean, if you can believe the organization, he had membranous. He's had it for a while, and it's resolving. And he just waited till 75 pounds when he got here, and he was kind of on the mend. He was getting better. He had no new deposits. The immunofluorescence was negative, and he had a spontaneous remission, which brings up really the interesting question of maybe this was an exposure. Maybe this was a NEL1. And it was also segmental, remember? we had a NEL1 membranous GN that it's spontaneous remission, and we don't know what prompted the whole thing in the first place. That's the
No.
best thing the best way
No one
that
has
Pravir
a
and I
high-
can put it together. Steve, you keep shaking your head.
High spontaneous remission rate.
I'm just trying to make you paranoid, Roger. Yeah, this whole thing, I mean, we know he wasn't taking NSAIDs, I assume. I mean, something to resolve that quickly. You
I
start to
asked
wonder,
them 100 times, like, are you sure? Especially after that, I was like, you sure you're not taking anything?
no
Nothing.
viral
And
illnesses or anything to consider
Nothing.
things like parvovirus B19 that could spontaneously get better. Because I agree. I mean, if you do nothing, and then all of a sudden, not only does he have a diuresis, but his proteinuria starts to get better and his renal function gets better. Very suspect.
Yep. So these are the old slides, David.
It's
just sent.
almost as if the membranous is kind of like the red herring, as Roger would put it.
And this is what you're saying, David, over here. This kind of
Yeah, this was a case from 10 years ago. Actually, Dr. Corbett, it was your case.
There you go.
I can't
sorry.
say the patient name because everything's, de-identified.
I took it out. I took it out.
But
Well,
you'll have
to tell me who it is, and I'll look it up again. They must have gotten better no matter what.
So this is this, and then this is the other picture. You can kind of see the same thing. A little better here, actually, in a lower power.
Pravir, do you buy my my kind of putting the whole thing together? I mean, I don't know how else to do it.
No, that's after that. So I was actually okay. I'm gonna see him as an outpatient. I'm gonna have to make this tough decision, and exactly what everyone said. I kind of held off on anything. I was thinking, okay, maybe I can do a CNI. He has so much proteinuria. His albumin is so low. I mean, he's on anticoagulation. What am I going to do? I knew I was going to add something outside of just an ARB. And then his proteinuria cuts back, and so it comes down. And now his creatinine's 1. His albumin is not better yet. So at this point, I think something happened. There's some inciting factor, and I think I just caught him at the end stage of it based on what I'm putting. There was some factor, and it could have been an L1 maybe or something exposure, but it had to be. It's something that he spontaneously remitted from whatever the exposure was. That's how I put it together. I have no other. I'm going to do genetic testing once I see him in clinic. I still think that's worthwhile given how his course has been. But genetic testing. But at this point, I'm not going to do anything further.
And
So
hopefully it'll continue to get better.
Is there such a thing as a spontaneous recovery in a burned out membranous?
Well,
I never heard of that.
I
Well,
don't.
don't you think that some membranuses can just completely resolve and the proteinuria goes away? I've seen that, and ironically, syphilis.
That quickly?
Well, I don't know that it was that quickly.
No,
I mean,
It's over months and months and months.
yeah, but he was healing. If you looked at the membranes were starting to resolve. There was only one new deposit that was very segmental.
Well, as Bill, I think, has always said, it's not about the deposits, it's about the podocytes. So
Fair enough, but the podocytes. This is not two diseases. The podocytes having something to do with the membrane, the deposits being deposited.
I asked Dr. Nasser about that exact thing because I was kind of looking at the podocytopathy. I was like, why can't this just be T cell has a podocytopathy before the proteinuria came down? And he said no, that he did not call it a podocytopathy. He said that's just from his chronic membranous, and he said he clearly said that he's not going to call this a podocytopathy.
I think I'm with Dr. Radby. I think he had a NEL1, and I have seen few cases of NEL1. They look exactly like that, and I think he's spontaneously dissolved, and they actually dissolve quite rapidly, actually, within few weeks, actually. So I think it's a NEL1 membranous nephropathy which resolved spontaneously. What caused it? I don't know. He has a previous history of testicle cancer. Did that play any role, or he was using anything else? That's the way I see it.
the testicular cancer was historic, right? This wasn't something recent.
Yes, it's like within the last year. It was within the last year.
But I thought the impression he was cured.
He was cured. He was in remission, and he had a full CAT scan and all that stuff while he was inpatient. There was no, oncology.
Is there any way, and this is probably you've already answered this, but there's no way to resolve the issue of whether he's NEL1 positive or not?
No.
Well, you can do the IgG subclassification if you don't have NEL staining.
unless I do another biopsy.
No.
That's exactly right.
Yeah,
That's
the
what he
IgG
needs.
was completely negative.
Yep. Yeah,
Mayo
it
does
is
have the
including,
stain.
yeah.
Mayo does have the stain.
Well, hopefully,
Bill?
hopefully, is all's well that ends well, even if we don't completely understand it.
Well, that's,
There is a good question that Dr. Rajsekaran asked about stopping anticoagulation. Would you base it on his proteinuria? You think it's, or his albumin, serum albumin? I mean, his proteinuria has gone down. He should be less hypercoagulable, but his albumin's still low. I think.
That's a great question. I don't know the answer to that. Right now, I still have him on him. I'm going to follow his proteinuria and make sure this is, there's been a couple that are low, so I don't think it's an
well, as
outlier.
his proteinuria improves, unless he's got malabsorption or some synthetic liver issue, which you've already said his coags are normal, that
It'll come
albumin
up.
should start to come up over
Should.
time.
Yeah, he's been very sick, so I think it'll take some time. Dr. Hyde asked about if he relapses, would you Rituxan if it was NEL1? I don't think, independent if it was NEL1 or not. If his proteinuria shot up for whatever reason, I would give him rituximab.
Why wouldn't you biopsy him then?
You could biopsy him again. I don't know. That's reasonable. Yeah.
Yeah, I think he needs genetic studies because this urea cycle defect may or may not be linked to his kidney disease. I have no idea, but I think he needs that. And the minute he relapses, my goodness, sharpen the needle and go for it.
Oh yeah, yeah, absolutely. I think if he hadn't gotten better here, I mean, I would have considered it. But he had such a prolonged course, and I think that's partly why his albumin hopefully is still low. That means he'll slowly get better. He's still in rehab, so I'm hoping that when I see him in outpatient follow-up, he'll be doing better and kind of go from there.
Dr. Rubin, you're always consistent about insisting on biopsies. We have to keep you coming.
Diagnostic, therapeutic, and prognostic.
All right. We're going to wrap this up. Great case, a lot of fun. I think we'll be off next week, but keep an eye on for your email. Thanks, everybody. Thanks, David. Great discussion, everybody.